lecture. In this section, we're going to be focusing on pain modulation and all of the different electrical stimulation modalities and setups that apply to decreasing pain as the main physiologic response. So let's look at these two theories first. So we have talked quite a bit already about the gate theory of pain control. So let's just do a little refresher here. So what does the gate theory of pain control really mean? Well, this theory suggests that the perception of pain can be reduced by closing the gate in the spinal cord that allows pain signals to reach the brain. So that gate is modulated by non-painful sensory input or non-noxious stimulus like touch, like light touch, vibration, in this sense, this nice tingling sensation from the E-Stim unit, which can compete with and block pain signals. So some of the applications that we're going to utilize this gate theory of pain control with relate to TENS, transcutaneous electrical nerve stimulation. And the reason it works so well is because it's activating these large diameter afferent nerve fibers, those beta fibers that carry the non-noxious stimulus to the spinal cord. Those non-noxious stimulus then close the gate in that dorsal horn of the spinal cord, preventing smaller pain-carrying C fibers and delta fibers from transmitting their signals to the brain. Okay, so you can see some of those results pretty quickly whenever you're applying something like only sensory kind of level input electrical stimulation. The results are immediate but very short-term pain relief. So the gate theory of pain control is great for short-term pain relief, but it's not typically going to be a long-lasting answer to this person's pain. Now, one that we've kind of briefly mentioned, but really haven't discussed much of, is this opiate release theory. So this theory relies on the body's natural pain relieving mechanisms through the release of endogenous opioids like endorphins to block or counteract these painful stimulus. So electrical stimulation activates a descending pathway in the brain and spinal cord that promote the release of these different chemicals, reducing pain perception. So typically the main difference is the parameters and how we set up these applications for E-Stim. So we're going to see the differences and feel the differences in the lab setting whenever we're trying to initiate gate theory of pain control, used probably better for acute injuries, and the difference between opiate release type application, which is probably better for prolonged relief of pain, chronic pain, those types of things. So again, some of the benefits, gate theory of pain control, it does decrease pain, but in the very short term. Whenever we're trying to stimulate this opiate release theory via these natural endorphins released by the body, these endogenous opioids, this is going to be a longer lasting pain relief. So if your patient can tolerate these opiate release type parameters, it's probably going to be better for them in the long run because they're going to get more pain relief for a much longer period of time. So we will talk about something like high rate TENS, which relates to the gate theory of pain control used for acute injuries. And we're going to talk about low rate TENS, which relates more to the opiate release theory of pain control for more of a chronic injury. So there's going to be differences in the parameters. We talked about the frequency in our last lecture, as well as the phase duration. Those are going to be really key whenever we're trying to determine the best parameters to get these results. Are we trying to get gate theory of pain control, or are we trying to get opiate release theory of pain control? So you really need to know the difference between these two. Start making that kind of mental note. Gate theory, acute pain. It's only going to be sensory information, that light tingling sensation that we're going to feel. With opiate release, you want to kind of associate that with more of a chronic type injury, and we may see some small twitches or contractions in the muscle, which is going to stimulate the release of these endogenous opioids. So make that connection, because that's going to be very important for choosing the correct parameters in our lab setting and for your quizzes in the future. So the next application of E-Stim that we're going to talk about is interferential current, or IFC. IFC is a type of medium to high frequency alternating current used in physical therapy for pain management and muscle stimulation. So remember what that alternating current looked like. It's going to be a sinusoidal wave that's going to be very comfortable for our patient. IFC is particularly valued for its ability to penetrate deeper into the tissues compared to other forms of electrical stimulation. And we're going to look at why that happens here in just a second. So we're basically going to use two medium frequency currents. Okay, so IFC uses two alternating currents with slightly different frequencies. So I have the example there of one current being at 5100 hertz and the other one being at 5000 hertz. Now the difference between those two hertz equals your beat frequency, which is 100 hertz. It's also really important to know that when we're setting up IFC, we're using a 4-electrode placement in a crisscross pattern around the treatment area, which is very different than most of the setups that we have for other E-Stim applications. So we're going to use 4 pads, and we have to make sure that we get this interference pattern, which is the result of both of those currents crossing in that treatment area. So when those two currents intersect at the treatment site, they create that interference pattern. This results in that low frequency beat like we saw earlier of 100 hertz that the body perceives. That beat frequency at 100 hertz is really effective for stimulating sensory and motor nerves, kind of making it suitable for pain relief and muscle activation, just depending on if we're setting a high rate or a low rate, so gate theory of pain control or opiate release pain control type settings. And due to the use of medium frequencies, this IFC application penetrates deeper into the tissues with less discomfort for our patients. So again, making this an excellent choice for treating what we call deep-seated pain or larger treatment areas. So that'll make a little bit more sense whenever we see an image of this. Okay, so this is what I was talking about when we're looking at using this 4-pad setup that are interfering with each other. So we have 1 and 1 kind of at the right bottom of the image and the top left of the image, and we have 2, 2 going from the top right to the bottom left. You can see that those currents are going to cross at a certain point or intersect with each other. They're going to interfere with each other, which is what creates this low frequency type sensation in the tissues of 100 hertz. So for anything skill competency related, it's going to be really important that we check each lead that comes off of the tower, and we need to make sure that the pads from each lead are basically diagonal to each other, and that the second lead makes that interference pattern possible. If you could imagine that both 1s were on the left-hand side of the image and both 2s were on the right-hand side of the image, you would see those patterns traveling from 1 to 1 and 2 to 2, and they would never actually cross. There'd be basically 2 vertical lines where the currents are not intersecting, and that's not going to be very beneficial for this application. You may still feel some sensation, like the tingling sensation, the sensory component of that, but we're not getting the interferential, we're not getting that interference of those two currents, which would give you this treatment parameter of 100 hertz. So again, this may not make a whole lot of sense until we get into the lab, but it's important to maybe just take a mental image of this picture because this is how we're going to set up IFC in the lab setting. Okay, so now let's look at interferential current IFC parameters. So I have two different, those two different theories of pain control, the gate theory and the opiate release theory. We're going to set different parameters to try to get either all sensory, kind of for that acute pain, or all opiate release, kind of maybe some muscle twitching, also sensory, but for that chronic pain. So let's look at the gate theory of pain control first and those parameters. So we see a beat high of 150 beats per second and a beat low of 80 beats per second. That just means during the cycle in which the current is on and it's continuous for IFC, you're going to be kind of switching back and forward between 150 beats per second and 80 beats per second. And the beats per second, if you remember from our last lecture, are referring to the frequency. So that's the parameter that we're setting here. That's what beats per second are related to. And setting the frequency is an essential part of targeting either the beta fibers, which is what we're going to talk about first, or the A delta fibers and potentially the C fibers, which is the opiate release theory. So when we use these high frequencies, 80 to 150, we're stimulating those B sensory fibers, which carry those non-painful signals to the spinal cord. Just remember that's also non-noxious. We kind of talked about how those different signals compete with the A delta and C fibers and close the gate effectively. So we're trying to stimulate those beta fibers using a higher frequency. Again, 150 and 80. Okay? So whenever we use the opiate release theory of pain control, the frequency is much lower. So we have beats per second, high of 10, and a beat low of 1 beat per second. The low frequency stimulates the A delta fibers and the C fibers potentially, triggering that release of endogenous opioids in the brain and the spinal cord. These opioids bind to receptors, reducing pain perception. So you're going to have a delayed onset of pain relief, but the effects are going to be much longer lasting, several hours compared to just when the machine is on for gate theory of pain control. So again, gate theory, we're going to utilize this for our acute injuries. Opiate release theory, we're really going to target for chronic injuries. Okay, so we can use, even with IFC, a high rate, essentially, a beat high of 150 and a beat low of 80 to stimulate that gate theory of pain control or closing the gate, or we can utilize the opiate release settings with a low frequency, beat high of 10, beat low of 1, to stimulate the A delta fibers. Okay, and then we also have this last component here that talks about carrier frequency. So let's talk about that really quickly, and then we'll move on to the next slide. So the carrier frequency is going to be one of the, I wouldn't say it's not important in our parameters and our settings, but for our purposes, we're going to worry about the frequency, either being beat high, beat low of 150 to 80 or 10 to 1 to either get gate theory or opiate release theory. But the carrier frequency, basically the higher the frequency, the less skin resistance we get, which allows the current to penetrate deeper into the tissues with less discomfort compared to lower frequency stimulations. So typical frequencies that you will see are 4,000, 5,000, and 2,500. So a lot of the ones that I've seen, at least from like the Chattanooga website, they recommend using 4,000 hertz as the carrier frequency for anything related to like the gate theory of pain control. They recommend 2,500 hertz if you're going to use the opiate release theory, and then they use 5,000 to stimulate a nerve block, essentially. So there's going to be less of a focus on you being able to select the carrier frequency because it doesn't really affect the beat frequency of that 100 hertz that we were looking at earlier. So, but just the only thing I do want you to know is that the carrier frequency, again, the higher it is, the less skin resistance that we're going to have, which allows that current to travel deeper into those tissues. Okay, so here's a nice little table that you have. It talks about the frequency on the far left side. Then it also talks about the depth of penetration, applications, and comfort. So if we look at the first one, 4,000 hertz, this is medium to deep penetration of those tissues. Applications, general pain relief, edema, and it gives you a balanced comfort. For 5,000 hertz, this is the deepest penetration that we can get. So applications, deep-seated pain into the joints. So if they have, a side joint pain and you're trying to target that low back area, maybe 5,000 hertz would be best to get deep into those tissues, or if there's any joint that they have pain in, osteoarthritis, something along those lines, you can set that carrier frequency at 5,000 hertz. This is going to be the most comfortable, again, because we have less skin resistance here. And then we go down to 2,500 hertz, which is shallow to medium penetration. We're looking at using, we're trying to elicit some type of muscle contraction with this one possibly, and it could be slightly less comfortable for your patients. So that was basically everything that you need to know about IFC minus the actual application of it, which we're going to see in lab. So let's talk about transcutaneous electrical nerve stimulation, or TENS. So TENS is primarily used for pain relief by stimulating the nervous system with electrical currents delivered through electrodes placed on the skin. The type of current that you're going to see that's commonly used with TENS is a pulsed biphasic current, and that just means that the current alternates directions in pulses. And this helps to minimize the risk of skin irritation, and it prevents charge buildup under the electrodes. So we looked at that in our last portion of our lecture. No charge being delivered to the skin here. The therapeutic effect of TENS depends on the frequency setting, as it targets different pain control mechanisms. So we're going to talk a lot about the gate theory of pain control and that opiate release theory. So let's talk about these low frequencies first. The low frequency, anywhere from 1 hertz to 10 hertz, stimulates the release of endorphins, those natural painkillers, by activating the A delta and the C fibers. So again, this is often used for chronic pain due to its longer lasting relief. And when you're applying this low frequency setting, as far as the patient experience goes, they may feel a strong muscle twitch during that treatment, which is very different from the higher frequency settings. So we'll look at these higher frequency settings and all the parameters maybe on this next slide or coming up very soon. Just remember that the high frequency settings stimulates those beta fibers, okay, which block signals at the spinal cord via that gate control theory. So again, this one's usually used for acute pain. Temporary relief, but it's not long lasting. The only thing a patient should feel here is a comfortable tingling sensation. So when you're thinking of low frequency, you may see that muscle twitch, and it may be fairly strong for your patient. With the high frequency setting, you're only going to feel the sensation of tingling, okay? So if you set up somebody on high frequency settings and you turn the amplitude up too much or that intensity up too much, you may get a nerve or a muscle contraction. That's not what we're going for whenever we're utilizing these high frequency settings. Okay, so again, try to kind of think of that low frequency, possible muscle twitching used for chronic pain, high frequency settings. We're trying to stimulate beta fibers, and we're trying to use gate theory of pain control. It should only be sensory. Okay, so these are the parameters I want you to know for TENS specifically. So like we mentioned just a second ago, this is a pulsed biphasic current. The pulse frequency, if we're using high rate TENS, ranges from 100 to 150 hertz. If we are using low frequency settings, the opiate release theory, it's going to range from 1 to 10. Okay, so remember, 100 to 150 is high rate. That's gate theory, only sensation. 1 to 10 is low rate. We're probably going to see some muscle twitching here. That's the opiate release theory. If you remember what the pulse duration is, or that phase duration is, the way that I think about this is the longer that pulse duration is on, the higher likelihood we have of eliciting a muscle contraction. So if we're going to use high frequency, this is gate theory of pain control, we want a low pulse duration of 50 to 80 microseconds. That's going to ensure that the current isn't on long enough to elicit a muscle contraction. But if we're using the low frequency settings, 1 to 10, this is opiate release, we want that pulse duration to be significantly longer because that's going to help induce a muscle contraction. So we want that setting at 150 to 300 microseconds. Okay, so if we're using high rate, high frequency, the pulse duration is going to be lower. If we're using low frequency, low rate settings, that pulse duration is going to be higher. So they're essentially opposite of each other in that sense. As far as the amplitude goes, we're going to set that intensity for our high rates to a nice comfortable tingling sensation, only sensory. If we are using the low rate settings, we can elicit a muscle contraction. These little twitches is what you're going to see. That's okay with the low rate settings, but not the high rate settings. Something that we'll also probably look at in the lab setting is the mode. So we have continuous, burst, or modulated. That's really just to help with accommodation for these different sensory inputs. So we'll talk about that a little bit more. Don't worry about that so much for right now. Okay, so that takes us to the end of the pain modulation section of these lectures for E-Stim. Hopefully this was helpful. I know the parameters can be a little bit intimidating, especially when you haven't had that lab practice, but study those tables. Make sure you go back and look at the high rate TENS parameters, the low rate TENS parameters. Make sure you look at the IFC parameters for high rate and low rate, and that you just understand that anything with a high frequency is going to be, we're trying to activate that gate theory of pain control. So we're using non-noxious stimulus to block pain receptors or these painful stimulus from reaching the brain. Anytime we're using the low rate settings, low frequency, we are trying to stimulate the A delta fibers and possibly C fibers to release endogenous opioids to give us pain relief. Last thing to think about is that gate theory of pain control is going to last, like the pain relief is going to be very immediate but not long lasting. The opiate release theory is going to be maybe prolonged. You're not going to feel that pain relief maybe right away, but you should feel pain relief for a much longer period after the application is turned off. Okay, so hopefully this helped. In our next section, we're going to talk about strength and neuromuscular reeducation applications of E-Stim. So reach out to me with any questions you might have, and thank you for stopping by.